Right, so today was part of an educational session on the role of immunotherapy in ALL, in pediatric and adult ALL. And my topic was specifically, what's the role of transplant once we have all these new agents? Are these agents good for transplant, or are they going to replace transplant? And so I think there's several key points from this. First of all, we're learning that transplant is still very important in the management of patients with acute lymphocytic leukemia, both pediatric and adult. While we can cure many patients with standard therapies, many patients do relapse or still have persistent disease, and that's where transplant has traditionally been used. And so the new data this year is that, for example, you can take patients with first remission but with minimal residual disease and actually treat them with blinatumomab and get a high degree, about 80% of patients go into MRD negative remissions. And if they're in their first remission, that some of those patients appear not to need a transplant. So that's kind of new. Rather than transplanting everybody, we're using MRD, or minimal residual disease, at a level of 10 to the minus fourth as the kind of predictor of how well people are going to do. And then we have two new treatments of blinatumomab and inotuzumab, both approved based on beating standard of care, and they both can get people with refractory disease, in some cases, back into remission. In those cases, however, that's not good enough, and they need to go to transplant because those patients will fail otherwise. So that's kind of the new news about the transplant part. So then the real question is about, what about CAR T cells in ALL? Do we need to transplant patients who are in remission or not? And that's really the jury is still out. I presented data from our group that Kevin Hay presented a couple days ago in an oral session, where we actually showed that patients still benefited from transplant if they were in an MRD negative remission after CAR T cells. So our policy in Seattle at the Fred Hutch is really to recommend or generally consider transplant in patients who are transplant naive if they go into complete remission after CAR T cells. Now, many patients are still reluctant to do that because there's risk. I mean, there's non-relapse mortality. And so in that setting, if you're not going to do a transplant, then you have to kind of keep an eye on whether the CAR T cells are still present. Do you still have B cell depletion? Can you detect the disease by, for example, deep sequencing? And even those tests are not really good enough, because patients can still relapse with CD19 negative leukemia. In that case, you could still have T cells present that essentially weren't able to now kill the tumor. So we still think in adults anyway, there's a role for transplant in transplant naive patients. In pediatrics, it's not quite so clear. The data presented from the UPenn group and in the trial, the tisagenlecleucel trial, they had already about 61% of patients already had a prior transplant, and so it's hard to do a second transplant in that setting, and so they generally tended not to do it, and they had fairly reasonable outcomes. So that's where my educational session went today.